Dave. Up next, Heartflow co-founders, Dr. Taylor and Dr. Zarins. Please come up.
Thank you very much. Thank you, Dr. Lunson, for inviting us to this pumps and pipes session. And at your opening remarks, you said this is different groups, different specialties coming together, different fields coming together to come up with something new. So here we have a vascular surgeon and an engineer working on a cardiology problem. How did that happen?
We're going to tell you about that. We'll tell you the story today. So I know the title was Idea to IPO, the Heartflow journey, and I would say, Chris and I, sometimes we jokingly say Heartflow was a 15-year overnight success. Actually, it took a lot longer than that. We'll tell you about that, and no path from idea to whatever successful business is a straight line. It's not a straight journey, and we'll tell you a little bit about that. So for us, that's Chris and I in front of the NASDAQ, and it's on August 12th, Heartflow is listed on the NASDAQ. That was the IPO. So really the focus of Heartflow is developing a technology to be able to address clinical problems related to the number one cause of death, coronary artery disease. And as you hear this story, it was a story that started quite some years ago, but now is a technology that combines medical imaging, AI, and computing to be able to better diagnose coronary artery disease non-invasively. A lot of the alternatives at that time, when we were starting to think about it, the alternative was typically taking a patient to the cardiac catheterization lab and do an invasive exam. And now this is a technology that can not only diagnose disease non-invasively, but could be used by physicians to be able to manage patients with coronary artery disease over the course of their lives.
So Heartflow manages coronary artery disease for life. What does that mean? Avoid premature death. So let's talk about coronary artery disease. We all know that it's a manifestation of coronary atherosclerosis. Chest pain is a very common sign. You know all about the risk factors. We all have heard about that forever. What most people don't know is that more than 50% of all people who suddenly drop dead of a heart attack have never had a symptom. The first manifestation of coronary artery disease is sudden cardiac death. You talk to any cardiologist, they all say, yeah, we know that. And I say, well, don't you worry about that? I mean, all you talk about is patients with symptoms. And the interesting thing is most patients with sudden cardiac death don't have risk factors. They're younger adults. And this is really a surprise when all of a sudden someone drops dead of a heart attack. So let's start with a patient story. The president of the American Heart Association. In 2017, he was the president. He gave a presidential address. And he said, there are no old men in my family. He knows his grandfather had coronary bypass. On his maternal side, patients died, the fathers died of heart attacks. So he gave his presidential address. If anybody knows about heart disease and how to avoid it, it's the president of the American Heart Association. So he gives his presidential address. The next morning, 6 o'clock, he goes to the gym like he always does, rides an exercise cycle, comes back to his room. His wife is in the bathroom. She hears a big clunk, comes in, and he's turning blue, cardiac arrest right there on the floor in the hotel room. Well, as president of the American Heart Association, you get special treatment. You get a big suite, and so he invited his wife and children to come to his presidential address. Normally he goes to all these meetings alone. He doesn't have family with him. They hear this, the wife screams, the children run out to the hallway. This is a cardiology convention, so the whole hotel is full of cardiologists. From the next room, a cardiac specialist came in with a cardiac nurse. They give CPR. The hotel brings an AED. They shock him. First shock doesn't work. Second shock, he resuscitates himself, starts breathing. EMT comes. They take him to the hospital. He's only 2.7 miles away. UC Irvine, he's in California. They resuscitate him. They recanalize his left anterior descending, and he survives. So what does he say? He says, if it can happen to me, it can happen to anyone. And what's his recommendation? His recommendation is everybody needs to learn CPR. You have to have AED devices. And you should teach high school students on how to do CPR. Another patient story. Again, 52 years old, athlete. He's run 39 marathons in his life. He has a little vague feeling in his chest occasionally, never when he's running. Goes to the doctor, they do a cardiac CT scan. Here you see the CT scan. Where the arrow is, he's got a plaque in the left anterior descending. That's the widowmaker. You don't know if that's really significant. So they do a PET scan, positron emission tomography. That's the best, most accurate test for myocardial perfusion. 100% normal. So they say, well, that CT scan must be something wrong with that because it's not really a significant study. You just take your statins, keep running, do everything you're doing everything right, you're watching your diet and exercise and taking medications. 1 year later, sudden cardiac arrest. He's out on the street. EMT comes, they resuscitate him in 6 minutes. They get him going, they take him to the hospital, and here's the angiogram. You see the angiogram with the arrow pointing to the blocked left anterior descending coronary artery. They recanalize that and open up the artery. He survives. The doctors send a CT scan to us at Heartflow. They say, evaluate the CT scan. We do the study, and you can see there's a big problem with perfusion, all the red. That means ischemia. It's below the stenosis in the left anterior descending artery. It's a very severe stenosis.
0.52 means that it's 52% of the blood flow that should be going through that artery is going through there under stress conditions. So significantly reduced.
But the important point, this CT scan was from a year ago. We were blinded to it. It's not one that was done now when he has this event. This could have been predicted and treated 1 year earlier.
So this is an example of a patient obviously who had significant coronary disease. The patient did not get treatment, obviously had a myocardial infarction. Sometimes you do a CT scan, and I would say historically, a lot of patients that have a CT scan, you see disease like you see in the top left, and the patient immediately goes to cardiac catheterization for further evaluation. This analysis is negative, though, with FFRCT, and what we've been able to prove over time is that you can safely defer cardiac catheterization. Actually, the majority of patients that end up in a cardiac catheterization lab don't have functionally or significant disease, obstructive disease, and they don't have functional significance. So the question is, how do you also find the negative patients, the normal patients, the patients that could just be managed medically that don't need a trip to the cardiac catheterization lab? That's the patient at the top, a negative study, negative physiologic test. The patient on the bottom is another positive test. These are patients that you need to identify. You don't want to miss these patients. Identify these patients because they will most likely benefit from a trip to the cardiac catheterization lab in a coronary revascularization procedure. So let's tell you a little bit about obviously what was behind this. We're actually showing you some results from the Heartflow analysis in negative cases and positive cases. We'll tell you a little bit about the Heartflow journey. Well, this started for me. Actually, I was pretty young when Chris started doing research in this area. But we're going to hear a little bit about his story, about where this originated, and this this fortunate opportunity that we had to meet each other afterwards. Chris?
Yeah, so the background really starts 50 years ago when I started as a young assistant professor at the University of Chicago to develop vascular surgery. We knew how to do bypasses and endarterectomy, but back then if you wanted to know why a patient died, you had to do an autopsy. We still didn't know about cholesterol. just the research was just starting. And at the University of Chicago, there was a SCORE, Specialized Center of Research in Atherosclerosis, one of 5 centers in the United States to try to learn what's going on with this problem of heart attacks and deaths. And after this research, with the development of statins, the development of stents all came. But I, as a vascular surgeon, asked the question, well, if it's cholesterol that really causes the problem, how come plaques are localized to the carotid, to the coronaries, and to the lower extremities? Why not in the upper extremities? So we did a lot of research. We had animal models of atherosclerosis. We did flow models. We did a lot of research. And after 17 years, we had a real good handle on the relationship between hemodynamic factors and atherosclerosis. So then I went to Stanford University 30 years ago to start a vascular center. And I gave a lecture at the School of Engineering on blood flow and your health based on all the research we had done at the University of Chicago. And in the audience was a bright young student, PhD student, came up to me afterward and said, I'm looking for a project for my thesis. Do you have any suggestions? So I said, yeah, why don't you solve the 3-dimensional pulsatile flow field of the human abdominal aorta? Well, that's a mouthful. But it didn't faze Charlie Taylor. He said, sure, I can do that.
So I had just arrived at Stanford a year earlier, and I was doing, I guess, a little rocket science. Before I was at GE, I was working on aircraft engine design, and then I went to Stanford, actually funded on a project by the U.S. Air Force to actually look at applied computational methods to airflow over fighter jets, and it just was, I would say, pure chance, maybe fate, that I happened to see the flyer that caught my eye, Blood Flow in Your Health. I thought that looks really interesting. The main auditorium in the engineering school at Stanford, I fortunately saw it. It was that afternoon. I showed up and saw a lecture that actually would, when I saw it, I was pretty sure I didn't want to do airplanes anymore. I wanted to focus on blood flow and arteries, and went to see Chris the next day. And I think you said come back in 24 hours, and that was now over 30 years ago that we've been working together really closely ever since. Joint laboratory at Stanford. I joined faculty. I was about to leave Stanford, and Chris said, give me 1 week. I said, what are you going to do about a faculty position in a week? He went to see our provost, who was Condoleezza Rice, who waived the search, and they hired me on the spot, but in the division of vascular surgery in the medical school.
Yeah, and this was a key moment, because Charlie could have been a famous professor in the School of Engineering, but I hired him in the medical school. So now an engineer was an assistant professor of surgery in the medical school. And because of that, he came to the clinical meetings, he came to rounds, he looked at CT scans, x-rays, angiograms, and in a short period of time, he knew more medicine than most of my residents and fellows. So this, I think, was the key true collaboration, because we were both working together on a daily basis.
So one of the things I remember as I was a junior faculty, young faculty there, Chris, I remember coming into the lab, it was February in 1998, said, I'm going to be president of the Society for Vascular Surgery. We're going to do a critical issues research forum. I don't want to talk about doom and gloom. I want to talk about the future. You've been talking about this idea of predicting outcomes of interventions and planning surgical procedures. Let's kind of put your money where your mouth is. And at the Society for Vascular Surgery meeting in 1998, we introduced this concept of predicting outcomes of interventions in vascular surgery. Wrote a paper. This is really a key paper, this idea of predictive medicine, computational techniques, and therapeutic decision making, where we could take individuals' anatomy, physiology data, build computer models, and actually with the goal of designing improved patient-specific treatment plans. Over the course of years together working at Stanford, we really laid the foundation for this combination of computing, imaging, to be able to look at blood flow in the cardiovascular system. And along the way, around 2007, 2008, it became really apparent that coronary physiology or coronary diagnosis was just starting to change. Invasive pressure wire techniques were being used to identify those lesions that were most at risk, the lesions in the coronary arteries that would be most likely to benefit from stenting procedures versus medical management. And that was really the time where the question for us was, could we do this instead of an invasive pressure wire? Could we do this completely non-invasively? This is the genesis of the idea. And the idea was to be able to take medical imaging data, cardiac CT data that was being acquired, extract the anatomy, compute physiology, actually using many of the principles that Chris had discovered when he was at the University of Chicago. This really how blood vessels respond to flow. And then actually using these techniques, the rocket science of computational fluid dynamics, to be able to predict blood flow through the circulation completely non-invasively from a static CT scan.
So we knew we could do it, but we didn't know if it worked, right? Right? We needed to actually compare it to real life, real measurements in the cath lab. So in 2010, we went to Riga, Latvia, and this was the first in-human case. There's a man with a severe left anterior descending stenosis, as you can see, and measured FFR with a pressure wire. It was 0.92. Charlie and I were in the control room. I had the solution in my pocket. The cardiologist comes in and says, I'm sorry, that must be wrong. I mean, this is clearly a significant lesion. He puts in a new pressure wire, measures it a second time, rebalances everything. Then doesn't believe it, measures it a third time, it's 0.93. I pulled out from my pocket this FFR study, not FFR CT, it was 0.93. We were as surprised as he was, a perfect match. I said, wow, this stuff really works. So we did the first 20 cases on the basis of the first in-human study. We were able to get funding for now big-time clinical research, which is extremely expensive, and that's how Heartflow got founded in 2010. 3 controlled trials were formed, FDA clearance in 2014, and now with guidelines. So how did it really happen?
So it wasn't straight. It wasn't smooth, and I think this is true probably for about every entrepreneur's journey, is that you start out, you have this idealistic view, you're going to be public and it's a great exit, everything's going to be wonderful. But of course, there's so many things that challenges along the way. Oftentimes we talk about a valley of death between taking university research out, into getting FDA clearance. In fact, there's probably many valleys of death, many places where bringing, especially in medicine, getting through FDA clearance, but FDA clearance doesn't come with a check. You have to then go out and get reimbursement. You have to get it, you have to, break down biases, change behavior, for instance, deal with prior authorization issues, other barriers to payment, barriers to introduction of new technology. It was a very long journey, and of course, where things are going well, then the pandemic comes along, and essentially diagnosis of stable coronary disease gets kind of put on pause, because everybody's worried about going into the hospital and getting COVID, even though they had chest pain. And again, many other challenges along the way, until we got to the IPO in 2015. Next slide. So today, Heartflow, with a foundational technology, there's 4 FDA cleared products. There's two different products that actually have Category 1 CPT codes, Medicare payment codes. The first product, FFR CT, is essentially universally paid for. It's been now the subject of over 600 peer-reviewed papers, millions and millions of annotated CT images to be able to drive a deep learning human-in-the-loop AI solution. It's in over 1,400 institutions, and over 500,000 patients have been served worldwide. A really key milestone was also getting to the first AI product to be included in the clinical practice, in the cardiology clinical practice guidelines. Just quickly, go to next slide, Chris. We don't really have time to go into much detail, but the idea, the whole AI story was automated algorithms with human inspection and correction, this human-in-the-loop AI. So the annotated corrected images created a very well-curated, corrected data set that could be fed back into future generations of the product. This is a perfect foundation for really doing deep learning or artificial intelligence in medicine.
And not only can we measure FFR using computational methods, we can also do quantitative plaque analysis. And the more atherosclerotic plaque you have in your coronaries, the higher the risk. And we can now quantitate that. And not only can we do that, but we can also couple that now with the FFR-CT. Here you see the spectrum of disease. It can go from totally normal, all blue, to on the lower right, severe three-vessel disease with left main disease. These patients really need to be treated in order to survive. So the take-home messages. Coronary disease is the primary cause of death worldwide. It's often unrecognized, undiagnosed, and undertreated. So we can have a platform for early diagnosis and appropriate timely treatment can save lives by preventing heart attacks and cardiac death.
Thank you.